Usually when we talk about a medical diagnosis, there is this expectation of absolute precision. We kind of think of it like engineering.
Right, like it's a very mechanical, obvious thing.
Exactly. Like you break your arm, the x-ray shows a jagged white line, and the doctor simply points to the screen and says, well, there is the problem. We find a lot of comfort in that kind of binary visibility. Things are either broken or they are intact.
We really do prefer our medicine to be neatly categorized. But when you step into the world of tissue rehabilitation, specifically focusing on post-radiation trauma, that expectation of clear, immediate visibility just completely falls apart.
Yeah, it really does.
We are looking at a diagnostic landscape where the changes are microscopic, they are insidious long before they ever become, visible or anatomical.
Welcome to the Deep Dive.
Oh,
Today,
that's
our mission is unpacking a highly specific, poorly understood, but incredibly vital aspect of cancer survivorship.
It is such an important topic.
It really is. We are examining what role medical-grade dilator therapy plays in preventing vaginal tissue fusion. Clinically, that is known as vaginal stenosis, and we are looking at this in patients who are dealing with severe post-radiation mucosal dryness.
And to understand this, we are synthesizing a really dense stack of sources today. We have clinical guidelines, oncology nursing protocols from various NHS trusts, the comprehensive EVIQ guidelines out of Australia, and several scientific literature reviews detailing the actual cellular mechanics of this condition.
We are dedicating an entire deep dive to this because, well, pelvic radiation is a double-edged sword. It can absolutely save a patient's life from cervical, endometrial, or anal cancer.
Right, it is literally life-saving.
But the late-stage side effects can quietly and progressively dismantle that patient's quality of life. The cure leaves behind an environment that actively works against the body's natural function.
So this deep dive is about the fascinating, and honestly sometimes controversial, mechanics of how a purely physical intervention, the mechanical force of a dilator, battles the body's natural yet ultimately destructive healing response.
We are talking about the literal prevention of irreversible scarring and the fusing together of human tissue.
Exactly.
So whether you are a healthcare provider trying to elevate your survivorship care or a cancer survivor navigating this profound reality, or, just someone who is fascinated by the incredible, sometimes brutal mechanical battles happening inside the human body, this information will completely reframe how you look at tissue rehabilitation.
It really changes your perspective.
Okay, let's unpack this. Because before we can understand the cure, we have to look at the hostile environment the radiation leaves behind. Can you walk us through the timeline of this radiation damage?
Sure, so the sources break the timeline of radiation damage into two distinct phases. It starts with the acute phase. During the actual radiation exposure, the treatment is doing its job. It is destroying rapidly dividing cancer cells. But it is simultaneously carpet bombing the healthy mucosal lining of the pelvic organs.
Just total collateral damage.
Exactly. The immediate result is severe inflammation, massive cell death, acute radiation vaginitis, and ulceration.
Sounds excruciating.
It is. The acute phase is incredibly painful, but, well, it does eventually resolve over a few weeks or months. The hidden danger actually lies in the chronic phase, which is where the permanent architectural damage to the tissue really sets in.
Right, and this is where the blood flow issues start.
Yes. The radiation fundamentally damages the microvasculature. Those are the tiny blood vessels feeding the pelvic region. This leads to profound ischemic changes.
And ischemia basically means the tissue is being starved of blood flow, right?
Exactly. And that lack of blood triggers tissue hypoxia or a severe lack of oxygen. Without adequate blood and oxygen, the tissue atrophies. It begins to lay down scar tissue, resulting in what we call circumferential fibrosis.
So the connective tissue all the way around the vaginal canal just thickens and stiffens.
Right, it loses its elasticity entirely.
And on top of the tissue starving for oxygen and blood, there is the compounding factor of extreme mucosal dryness. The radiation to the pelvis, or sometimes the surgical removal of ovaries and the use of certain chemotherapy drugs, it just completely obliterates the estrogen receptors in the vagina.
It induces an immediate harsh menopause.
Right. And in a healthy estrogen-rich vaginal environment, the superficial epithelial cells, the top layer of skin, they shed every few hours. Because those cells contain glycogen, which is essentially a form of stored sugar, their continuous shedding provides a constant food source for the local microbiome.
That glycogen is the absolute foundation of a healthy pelvic ecosystem. It feeds the healthy lactobacilli, the protective bacteria.
Right.
As the lactobacilli consume the glycogen, they produce lactic acid as a byproduct. This continuous production of lactic acid keeps the vaginal pH safely acidic, usually under 4.5.
And that acidic environment acts as a chemical shield. It keeps the tissue moisturized, healthy, and actively repels opportunistic, harmful bacteria.
It is brilliant. It operates perfectly, like a vibrant rainforest.
Oh, I love that analogy from the sources. The canopy is constantly shedding leaves, which represents the glycogen.
Right.
Those leaves fall to the forest floor, feeding the soil and keeping the entire ecosystem lush, balanced, and highly resilient. But post-radiation, without those estrogen receptors, the rainforest is essentially clear-cut. It turns into this fragile, dry desert.
The mucosa thins out so dramatically that the superficial epithelial cells drop to less than 10% of their normal volume.
Wow, less than 10%.
Yeah. So with almost no cell shedding, the glycogen supply just vanishes. The lactobacilli starve and lie out, which removes that acidic shield we talked about.
And that is when the pH spikes.
Exactly. The pH of the vaginal secretions climbs above 5, creating an entirely different, highly vulnerable biome.
Commensal organisms like E. coli, which are normally suppressed by the lactic acid, suddenly have free rein to dominate the space.
Yeah.
And the tissue isn't just dry at this point. The sources describe it as pale and friable.
Friable meaning it is so brittle it tears and bleeds at the slightest friction.
Right, the underlying structure, the lamina propria, loses all of its architectural integrity.
It is a complete structural and chemical collapse. The tissue is desperately trying to heal itself in this dry, brittle, oxygen-starved state. But the mechanics of how the body attempts to repair this damage leads directly to the core problem of vaginal stenosis.
Which is the actual tissue fusion.
Right. Looking at the cellular level, the connective tissue relies on fibroblasts to produce collagen and elastin. That is what gives the vaginal wall its necessary stretch.
But post-radiation, those fibroblasts just shut down, don't they?
They do. They become dormant fibrocytes. The existing collagen fibers in the dermal layer undergo hyalinization.
Hyalinization. That means they literally take on a glassy, rigid appearance. The stretch is permanently gone.
Yes. So now you have two raw, inflamed surfaces resting against each other in a space that is now narrow, dry, and rigid from that glassy collagen.
And the body processes this the same way it processes any two open wounds placed in direct contact.
Exactly. It attempts to heal them together. The walls of the vagina can form dense adhesions, literally gluing the canal shut with heavy scar tissue.
It is a tragic irony, honestly. The body's desperate attempt to heal an acute radiation wound is exactly what causes the permanent structural damage.
It really is.
I was reading the case study in the sources, the one detailing the 68-year-old woman who underwent pelvic radiation.
Oh, yes, that is a very telling case.
She developed persistent worsening pelvic pain, and when her doctors examined her, they found a dense, crescent-shaped fibrous band of tissue that had formed right in the middle of her vaginal canal.
Right across the middle.
Yeah. It was physically impinging on the diameter, creating a rigid partial obstruction. Her pH was elevated to 6.5, and the surrounding tissue was entirely inelastic.
That case study perfectly illustrates the biomechanical failure of the tissue. You know, when people hear about vaginal stenosis, the conversation almost exclusively revolves around the loss of sexual function and the inability to have penetrative intercourse.
Right, which is obviously very important.
Preserving sexual health and intimacy is undeniably crucial for a patient's self-esteem and overall quality of life. However, focusing solely on sexual function entirely misses the life-or-death oncological stakes of this condition.
Here is where it gets really interesting and honestly kind of terrifying. If the walls fuse together and the canal significantly shortens, oncologists physically cannot perform routine pelvic exams.
They cannot insert a speculum to visualize the vaginal vault.
Right, because vaginal examinations are a mandatory non-negotiable part of follow-up cancer care. Losing that anatomical space means losing the ability to detect a local cancer recurrence.
If the cancer returns at the vaginal vault, early detection is the only window for successful life-saving treatment. If the canal is fused shut by dense adhesions, that window of detection is completely barricaded. The doctor is literally flying blind.
So knowing that the body is actively trying to scar, shrink, and fuse these raw walls together, the medical community relies on a mechanical counterattack to block that process.
Yes, the mechanical intervention.
This is the core role of medical-grade dilator therapy. A dilator is typically a smooth cylinder made of medical-grade plastic or silicone. And the underlying biomechanical theory is that physically stretching healthy skin and connective tissue stimulates mitosis.
Mitosis being the cellular division and creation of new epithelial cells.
Right. By regularly inserting this cylinder, the patient is using mechanical force to break down those flimsy early adhesions before they can mature into permanent glassy scar tissue.
What is fascinating here is that it forces the vaginal vault to maintain its length and elasticity by simply not allowing the opposing walls to touch and heal together.
But wait, looking at the condition of the tissue, this intervention seems incredibly counterintuitive.
How so?
Well, if the vaginal mucosa is severely dry, ulcerated, inflamed, and highly friable, introducing a rigid plastic or silicone tube into that space seems like it would just shred the fragile lining further. It feels like the mechanical trauma of the dilator would cause micro tears, create more bleeding, and ironically trigger even more aggressive scarring.
Your assessment of the risk is entirely accurate. It is a very real danger, which is exactly why the timing and the technique of this therapy are strictly, almost obsessively, governed by clinical guidelines.
So you can't just start doing this right away.
Absolutely not. If a patient attempts dilation too early, they will absolutely cause more severe, irreversible tissue damage. Dilation is never, under any circumstances, prescribed during the acute inflammatory phase of radiation.
The patient has to wait for the acute fire to completely burn out.
The superficial mucosa must be given time to heal from the initial ulceration. Clinical guidelines from EVQ and the NHS trusts generally mandate waiting until 2 to 4 weeks post-radiotherapy before initiating any mechanical stretching.
And the technique is equally uncompromising, right?
Yes, the use of copious amounts of water-based lubricant is mandatory to eliminate friction.
The sources are very specific about avoiding oil-based lubricants, as they can cause severe tissue irritation, trap bacteria, and actively degrade silicone-based dilators.
It has to be a water-based product to protect that thinning epithelium.
And many oncology teams will also heavily rely on prescribing topical vaginal estrogen cream alongside the dilator therapy.
Which makes a huge difference. Even a tiny localized dose of estrogen helps to plump the tissue, restore some of that glycogen cycle we talked about earlier, and improve local blood flow, making the mechanical stretching vastly safer.
So you are creating a highly controlled environment. You wait for the acute inflammation to drop, you flood the canal with safe lubrication, you theoretically improve the tissue quality with topical estrogen, and then you apply gentle, consistent mechanical pressure.
That is the ideal scenario, yes.
But when you look at the clinical realities of prescribing this therapy, the data surrounding its success and prevalence is incredibly chaotic.
Oh, the data's a mess.
The reported incidence rates of patients who develop vaginal stenosis after pelvic radiation are deeply frustrating to read. The sources show the numbers varying wildly, from as incredibly low as 1.2% to as catastrophically high as 88%.
A data spread that massive points to a fundamental failure in how the medical community tracks and defines the condition.
Why is it so fragmented?
It comes down to severely poor documentation and the lack of a standardized diagnostic definition. Some clinical studies define stenosis rigidly, recording it only if there's a measured loss of vaginal length falling below 8 centimeters.
Okay, so a strict measurement.
Right. But other studies rely entirely on subjective clinical judgment, defining stenosis merely as the inability of the examining clinician to comfortably insert 2 fingers.
Wow. When the medical community cannot even agree on the basic measurement tool, the broader data becomes entirely skewed.
Exactly. However, in the specific studies where researchers prospectively and actively monitor the patients with a unified definition, the rates of toxicity and structural change are alarmingly high. They consistently hover around 38% to 75% for mild to moderate stenosis.
So it is a highly prevalent, almost expected consequence of pelvic radiation.
It is, and because it is so common, the actual clinical protocols, what the patient is instructed to do with this device in their own home, have had to evolve significantly.
Reading the older medical texts referenced in the literature reviews is actually quite shocking. The historical guidelines essentially prescribed a medieval stretching regimen.
They really did.
Patients were instructed to use the dilator daily, leaving it inserted for 10 to 30 minutes at a time, and were told to maintain this grueling schedule for a minimum of 2 years.
Which is just wild.
Expecting a patient who is already physically and mentally devastated by cancer treatment to perform a painful, daily 30-minute stretching routine for 2 years is completely detached from reality.
The medical community eventually recognized that those older protocols were entirely unsustainable. The compliance data reflected that failure.
So what do the updated protocols say?
Well, the updated evidence-based protocols, specifically the modern EVQ guidelines, have drastically modified the prescription to be significantly more humane. The current recommendation is to dilate 3 times a week, for just 5 to 10 minutes per session, continuing for 6 to 24 months depending on the individual patient's tissue response.
The newer guidelines also provide much more flexibility regarding the mechanical device itself.
Hmm?
The sources explicitly state that any object providing the appropriate mechanical stretch will suffice.
Right, it doesn't have to be a specific medical brand.
A patient can use the clinical, medical-grade dilator provided by their oncology team, commercially available sex toys, or regular penetrative coitus, provided it achieves the necessary dilation. It basically operates on the same principle as physical therapy following a major joint surgery, like a knee replacement.
That is a great comparison.
The exact brand of the stationary bike the patient uses matters far less than the consistent, gentle, repetitive stretching of the repaired joint. The tissue simply requires the mechanical load to prevent the joint from freezing.
If we connect this to the bigger picture, the biomechanical principle is identical to post-surgical physical therapy. But the environmental and psychological differences between those two scenarios are vast, and they highlight a critical failure in our healthcare system.
Yeah, think about it. When a patient gets a knee replacement, they're usually sent to a bright, encouraging physical therapy clinic. They have a dedicated, highly trained physical therapist guiding them, monitoring their pain, correcting their technique, and cheering them on.
They are surrounded by a support system specifically designed to push them through the discomfort of rehabilitation.
In stark contrast, a patient recovering from pelvic radiation is typically handed a piece of cold plastic, warned that their internal anatomy might literally fuse shut, and then they are sent home to navigate this profound physical and psychological trauma in total isolation.
They are performing painful physical therapy on highly intimate, damaged tissue entirely alone.
This profound isolation leads directly to the most alarming, actionable statistic in all of our source material. Despite the life and death stakes of keeping the vaginal canal open for oncology follow-ups, the compliance rate for dilator therapy is devastatingly low.
It is incredibly low.
One comprehensive study noted that only about 33% of patients were considered adherers, meaning they managed to use the dilator more than twice a week during that critical first month of rehabilitation.
When 67% of your patients are failing a prescribed life-saving therapy, it is no longer a failure of the patient. It is a systemic failure of the survivorship care model.
Patients are abandoning the therapy.
Yes, due to intense fear, unmanaged pain, and a complete lack of professional ongoing support.
The simple act of using the dilator can trigger severe anxiety and serve as a visceral, painful reminder of the trauma of their cancer and the radiation itself. When they attempt the therapy at home, the tissue is often dry, inelastic, and highly uncomfortable.
And without a specialized pelvic floor physical therapist or a psychosexual counselor available to provide empathy, coach them through the mechanics, and manage the psychological burden. I mean, it is entirely rational that a patient would simply place the dilator in a drawer, close it, and try to block out the reality of what is happening to their body.
We're asking patients to manage a highly complex mechanical and psychological intervention without providing them the necessary tools or team to succeed. The medical system treats the prevention of vaginal stenosis as a purely mechanical issue, completely ignoring the human being attached to the tissue.
It is a profound oversight.
So what does this all mean? Understanding this entire process really demystifies a massive, often whispered about reality of cancer recovery. It completely reframes how we view survivorship.
It really does.
We start with a hostile environment. Radiation decimates the estrogen receptors and the local microvasculature, transforming a lush, self-cleaning, acidic ecosystem into a dry, fragile, oxygen-starved desert.
And in that devastated environment, the body's natural healing mechanisms are triggered, but they act destructively. The collagen hyalinizes into rigid, glassy fibers, the fibroblasts go dormant, and the inflamed vaginal walls attempt to heal their microscopic wounds by fusing together into permanent, unyielding scar tissue.
To intercept that fusion, medical-grade dilators serve as a critical form of localized internal physical therapy. By utilizing consistent mechanical force, paired with heavy water-based lubrication and timed perfectly to avoid the acute inflammatory phase, you literally force the anatomy to remain open.
It preserves sexual health, but more importantly, it maintains the physical space required for oncologists to perform the life-saving follow-up exams necessary to catch a potential recurrence.
It is a therapy about reclaiming physical ownership of the body after intense medical trauma. Understanding these hidden mechanical battles inside the body helps demystify cancer recovery and removes the stigma from a critical medical therapy.
It is a remarkable, heavy intersection of cellular biology and sheer mechanical force. However, Looking deeply at the literature reviews, there is a lingering, profound question that sits at the very edge of our current medical understanding, and it remains unresolved in the data.
Oh, really? What is that?
Well, we know that applying mechanical stretch to healthy skin unequivocally stimulates mitosis. Plastic surgeons rely on this principle constantly, using tissue expanders to slowly grow new, healthy skin for breast reconstructions or to repair massive burn injuries.
Right, stretch healthy skin, get more skin.
Exactly, but the skin inside an irradiated vaginal vault is not simply damaged or burned. The stem cells residing in that specific tissue have had their fundamental DNA altered and shattered by the ionizing radiation.
Oh, wow.
The actual blueprint for cellular regeneration has been compromised.
So the question becomes whether the rules of biomechanics still apply to a compromised blueprint.
Exactly the issue. Can the simple, repetitive mechanical pressure of a plastic dilator truly trigger healthy cellular regeneration and mitosis in stem cells that have suffered extensive radiation damage?
Or, wait, are they just tearing scar tissue?
That is the question. When a patient diligently uses a dilator week after week, are they simply using blunt force to physically tear apart fresh, flimsy scar tissue over and over again, just to keep the anatomical space from closing? Are we genuinely stimulating new, healthy epithelial growth, or are we just continuously mechanically managing a permanent internal wound?
Does the mechanical force regenerate the rainforest, or is the patient simply tasked with endlessly tilling the dry desert sand so it doesn't solidify into stone?
It is a fascinating frontier of tissue biomechanics that oncology researchers are still actively struggling to definitively decode.
That is a deeply profound, slightly unsettling thought to leave you with. Understanding the hidden microscopic battles occurring inside the human body changes how we advocate for better, more empathetic healthcare. Thank you for joining us on this deep dive into the complex mechanics of tissue rehabilitation. Until next time, keep questioning the systems and the mechanics of how we heal.